Good afternoon. My name is Robert Stevens. I'm an associate professor of anesthesiology, critical care medicine in the School of Medicine at Johns Hopkins University. I'd like to thank the organizers of Hopkins at Home and the university for inviting me to participate in this program. It's my pleasure today to speak about something which is very important to me, which is the question of precision medicine and why it's relevant today. I just want to also point out that any members of the audience who have questions should feel free to post them. I think there is a chat function which is made available. And hopefully I'll reserve about 5 to 10 minutes at the end of this talk so that we can engage in questions that are coming from the audience. So I think for many of you, this screen is familiar. This is the Johns Hopkins University COVID-19 dashboard. This was a screenshot taken a couple of days ago, and you can see the staggering figures. 14 million cases worldwide, 602,000 deaths, and these are from 48 hours ago, as I was saying. I recall just a few months ago, back in March, when there was just a single or a couple of dots in mainland China. And then I recall when there were just a handful of cases in Europe and then in the United States. And this is where we are today. And when I look at this, it inevitably leads me to a consideration of our history. I wanted to show you these images, which many of you will recognize are from about 100 years ago, just a little bit more than 100 years ago. These are images of the influenza pandemic of 1918, 1919. You can see that this was also a very significant health and social and political issue. You can see people wearing masks. You can see policemen that are ready to deal with social unrest. And here you can see a makeshift hospital that was created to treat people who were suffering from the consequences of influenza in 1918. The flu pandemic, as many of you know, was a very, very considerable event 100 years ago. It's estimated that more than 500 million individuals died. 500 million individuals were infected. Between 50 and 100 million died. 675,000 died in the US alone. And these numbers of deaths were actually significantly higher than the number of deaths that occurred during World War I, which was just preceding the pandemic. So the question is, are things going to be different this time? Many people think that yes, because we have better epidemiological models, we have stronger preventive measures, we have molecular diagnostics, we have personal protective equipment that's more sophisticated, we have antimicrobial therapies, we have therapies to modulate the immune system, and we have intensive care, which is the domain in which I practice. So there are many challenges, however, with regards to the pandemic today. One of them is that people are much more mobile in 2020 than they were in 1918. There's considerable social unrest that has been provoked by this pandemic. There's ambivalence, I think would be a mild term, of our political leaders. There's also ambivalence about economic policies. We know that the virus itself is highly transmissible, that it mutates. And we also know that the virus is not just a respiratory virus, that it can involve multiple different organ systems. And we know that, and this is the tricky piece, that it's extremely heterogeneous. So when I say heterogeneous, what I mean that people infected with SARS-CoV-2 can have no symptoms at all. And this is the case, we know, for probably 70 to 80% of individuals. We know that people can then develop mild symptoms, moderate symptoms, severe symptoms, and critical illness, which is the kinds of patients that I deal with in the intensive care unit. We also know that there are many, many atypical presentations of the disease. We know that the symptoms can be long-lasting in some cases. And there's even questions as to whether the virus can reinfect individuals who were infected in the past, which is currently unresolved. So this slide just documents the multi-organ or multi-system involvement of this disease. As we all know, this was initially recognized as a respiratory virus, but now there's ample evidence that it can cause damage to the kidneys, damage to the liver, it can change the coagulation system, it can cause cardiac problems, it can cause endocrine problems, gastrointestinal problems, and this is an area that is also under investigation, neurological problems, a range of sometimes very worrisome neurological symptoms. And the question is, how do we encompass a disease of such complexity? So here, just two examples of trials of therapy for COVID-19. These are antiviral therapies, remdesivir, lopinavir, ritonavir. These are kind of repurposed medications, remdesivir in the case of Ebola, lopinavir repurposed from other viral infections. And you can see that when we plot the improvement rate over time after receipt of the medication, that the treated patients and the non-treated patients had pretty much the same degree of improvement. So there was not a significant effect of the therapy. And these were randomized trials, right? So, and I want to show you this slide because it illustrates the current hierarchy of evidence in medical science, right? So we start with opinion, and then we have case reports, and then we have case control studies, cohort studies. But currently, it's thought that the highest level of evidence for demonstrating the efficacy of a treatment in medicine is the randomized controlled trial. And then the derivative of the randomized controlled trial, which is the meta-analysis, where you put together statistically a number of randomized trials to determine the efficacy collectively. The problem is that randomized trials are not terribly effective. It's been shown that between 60 and 85% of randomized trials actually are inconclusive, meaning that they demonstrate no significant treatment effect. And this is really kind of a statistical concept because randomized trials, for the most part, are designed to treat an average individual with the disease. But as we can see from this slide, there is a so-called heterogeneity, not only in the biology of individuals, but also in the treatment effects. What this means is that some individuals who receive the treatment may benefit, this is shown in green. Some may be harmed, this is shown in red, and some may actually not receive any benefit or any harm, and this is shown in gray. So this heterogeneity of treatment effects is actually a big problem. This slide illustrates the number needed to treat. This means essentially the number of individuals that need to receive a drug for it to be effective in a single individual. These are the top highest grossing drugs in the United States. You can see across these different drug classes, many different types of drugs, all of them very expensive. You can see that only a very small proportion of the individuals who receive the drug actually benefit. And so if we take a step back and consider what we invest in healthcare and in medicine today in the US, which is estimated, and these are figures from 2017, about $3.5 trillion spent on health and healthcare, 17% of our GDP. What we know is that, as we've just seen, that about approximately 75% of people receiving specific medications don't respond to those medications. We also know that there's a number of other problems, and these were highlighted in a recent talk by Dr. Eric Topol. So that we know that there are diagnostic errors of approximately 12 million each year. It's estimated that anywhere between 1/5 and 1/4 of hospitalized patients are harmed by medical errors. And we also know that the screening process, for example, screening for breast cancer, screening for prostate cancer, is not very effective. About 60% of patients who are screened actually do not benefit in any way from the screening process. We can carry this exercise a little bit further and talk about the relationship between how we invest in healthcare in this country and the outcomes of our health system. And I think it's no secret to many that the outcomes in this country, when compared to other comparable economically advanced nations, in this country, they are not very good, right? So we have one of the lowest life expectancies, we have high infant mortality, we have among the highest rates of obesity, of homicide, suicide, and drug-related deaths. And we have one of the highest rates of preventable hospitalizations. And these are figures from the Commonwealth Fund and also from the Institute of Medicine. So the question then is, are we making a good investment in our healthcare and our medicine? It's somewhat of a rhetorical question, but I think it also opens up the opportunity to think differently. So the question is, it seems that many aspects of medicine and healthcare are imprecise, they're ineffective, they're costly. And this, we believe, I think I believe, and many others believe, that this is probably related to the fact that diseases are intrinsically heterogeneous. reflecting the unique characteristics of the individual. So when we talk about precision medicine, we're talking about a novel, sort of innovative approach to health, which states that states of health and disease are a function of the unique characteristics of the person. And the corollary of this is that medicine and healthcare will be more effective and more efficient if they are individualized. So another way of stating this, perhaps more prosaically, is to say that precision medicine is to ensure that the right treatment is delivered to the right person at the right time. And this is not by any stretch a novel concept, right? So the great physician, Sir William Osler, who created the medicine program and was a leading physician at Johns Hopkins for many years, was famous for having said, the good physician treats the disease, the great physician treats the patient who has the disease. So the value of precision medicine, I think, has been recognized at the highest levels of government. This is the Precision Medicine Initiative, which was the initial name that this program had. It's now called the All of Us program. So this is a NIH-sponsored program which plans to enroll more than 1 million individuals across the country, people who are healthy, people who have diseases, and to document with a high degree of granularity the state of their health using a range of different methods, including clinical evaluations, imaging, biomarkers in the bloodstream, genomics, proteomics, you name it. So this program is ongoing. It's been ongoing now for several years. And it's quite clear that Johns Hopkins also has recognized the value of precision medicine. We have our own program here at Johns Hopkins, which is dedicated to precision medicine. It's called In Health, or Individualized Health. This was created in the past several years. And there are a number of different things that are, sort of deliverables that have come out of the In Health program. One of them is to establish precision medicine centers of excellence. So we have, for example, right now, Johns Hopkins, a precision medicine center of excellence dedicated to chronic obstructive pulmonary disease. We have one that's dedicated to pancreatic cancer. We have one that's dedicated to prostate cancer, to bladder cancer, to Alzheimer's disease. And most recently, our group in the Neurocritical Care Unit, which is where I practice, we also were awarded a Precision Medicine Center of Excellence. This is in neurocritical care. And the goal here is to leverage data that is being recorded in the Neurocritical Care Unit and to use statistical and machine learning methods to build models for prediction, classification, and to improve outcomes. So the question is, why precision medicine now? We saw that Sir William Osler had sort of hinted at it many, many years ago. And I think there are several important things that have occurred just in the past 10 years that I think explain why people are excited about precision medicine now, why we believe it's something that is realizable. The first is the advances in molecular sequencing, right? So we can sequence the genome very quickly for almost nothing, a couple of $100s. There have been significant advances in addition in imaging. We have access to very detailed information in the electronic health records. And we have the development of artificial intelligence. So if we look here, this graph illustrates the cost of sequencing the genome. And this has gone from many, many millions of dollars to sequence a single genome back in the late 1990s, early 2000s, to maybe a couple of $100s today. And so this is a fantastic evolution in our ability to gain this very, very important information on the health of individuals. And you can see here on this slide, there is a blue line which illustrates the sort of hypothetical cost of phenotyping. What that means is, what does it cost to bring a patient to a clinic or into the hospital to perform a physical exam, a history, to get an X-ray, an EKG, and maybe some labs? That's going to cost today much more than it costs to perform a genome sequence of that individual. So I think we've reached a sort of critical point here where the genome is accessible, and this means a lot of different things. It means that we have a multidimensional view of health, right? So in addition to the genome, we can collect data from the proteome, which is the expression of proteins collectively in the bloodstream, for example. We can collect data on the microbiome, which is the diversity of different types of bacteria and viruses that live in our gut, for example. We can collect data on the exposures that individuals have. We can collect data on their movements using sensors. We can collect data on their social and family contacts. So we are in a position right now to access a huge amount of data that is related to the health of individuals. And using advanced statistics and using machine learning, we can then generate maybe a more precise estimate of the multidimensional nature of health. So the way to do this is to implement data science. What do we mean by data science? It's an interdisciplinary field that employs computational methods to extract knowledge from complex data sets. And really, data science lives at the interface between these large data sets that I was referring to earlier, the use of machine learning techniques, and of course, strong biologic scientific hypotheses. So you can see that it requires an interdisciplinary team. You need computer engineers, you need data scientists, but you also need so-called domain experts. So these are physicians or nurses, people who know about human health and human disease, and who can inform the process of discovery to arrive at novel solutions. If we consider this slide, what I'm showing you here is essentially a graph that kind of portrays the way medicine is practiced now, which is on the left, and the way that medicine could be practiced with precision medicine. So on the left, you can see that at the top of this y-axis, you have large populations, and at the bottom, you have individuals. So a lot of medicine today, even, but in the past in particular, was practiced on the basis of trial and error. So physicians would examine a patient, they would think about the last several patients that they saw, and they would make inferences based on that, and then they would practice in a different way. This is the so-called anecdotal inference. So we certainly have evolved quite a bit from this individualized primitive medicine that existed in the past, because we know that the power of randomized controlled trials, we have standardization, we have protocols, we have consensus statements, we have clinical guidelines. And so we've developed a population-based approach to medicine, which is extremely powerful and which we need to continue, of course. But the question is, this type of analysis sets aside the high-dimensional nature of health data. So you remember that I showed you that slide with the multidimensional or high-dimensional aspect of health of the individual. This is not accessible to conventional analytical methods. It's what we call big data. And big data requires a special process with iterative computational modeling. But we believe that this big data can be leveraged, and we believe that it can lead to individualized therapy, which this time is no longer trial and error, it's no longer anecdotal, but it's actually highly personalized and highly precise. So the conventional workflow in medicine, again, extracts inferences from populations. The physician or the provider makes a diagnosis and then proposes a treatment or no treatment, and then an outcome is observed. So this is the way we practice medicine across the world today. Precision medicine is a little bit different, right? Because here we're talking about leveraging these very, very large, complex data sets, and then using statistical modeling and machine learning to enhance our ability to classify and to predict, and then to propose, precise interventions, and hopefully there see an individualized response to therapy and an outcome. So the types of inputs might include, for example, genomics that we were referring to earlier. It might include high-frequency physiology collected in the intensive care unit. It might include imaging. It might include data from the electronic health systems. And the outputs, or I guess the deliverables of this approach, include a new classification of disease, which we'll talk about in a second, but also a new type of medicine, which some people refer to as P4 or P5 medicine, which is predictive and therefore preventive. It's precise, it's personalized, and it's participatory. The other really, really exciting feature of this discovery cycle is the fact that data that is collected during the sort of prediction, intervention, outcome phases of the cycle are fed back into the system, into the big data system, and therefore you observe a kind of virtuous cycle where we're constantly not only using big data, but we're also constantly adding to that big data. And as many of you know, the machine learning algorithms work better the more data you give them. They're very data hungry. So precision medicine is here today in 2020. We have examples of precision medicine in cancer medicine and oncology. We have examples in rheumatology, immunology, neurology, and we have examples in a number of other specialties. Almost every single specialty of medicine is touched by precision medicine, including my specialty, which is intensive care. This is an example of oncology, right? So on the left-hand side of your slide, you see the traditional approach to classifying cancers based on the organ system in which these cancers are occurring, right? So this is for decades, for centuries, we thought about cancer as breast cancer, we thought about melanoma as a skin type of cancer, we thought about gastric cancer. But what you see in colors, the different colors represent different molecular mechanisms that are driving these cancers. And as you can see on the right-hand side of the slide, it may also be very useful to think about cancers not only in terms of the organ in which they are occurring, but also in terms of the molecular defect that is driving this cancer. And this is what is shown on the right-hand side. And so using these types of insights, we can design maybe different kinds of randomized trials. So we have the umbrella trial, where a single type of cancer, for example, lung cancer, is underlined by multiple different mechanisms. Therefore, multiple different biomarkers can be used to implement multiple different drugs based on the biomarker, what the knowledge that the biomarker is providing on the specific disease. And so this is the umbrella trial, right? So you segregate patients on the basis of the expression of specific biomarkers. And it's kind of the inverse of the basket trial, where you have multiple different cancers coming from different organs, but many of them share the same types of molecular mechanisms or biomarkers. And therefore, you can implement one or maybe two drugs to all these different types of cancers because they share the same underlying biology. In my field, intensive care, we've been very interested in leveraging data that is available to improve the care that we provide. So we've been working very much using the data from the electronic health records, data collected using the bedside monitors, imaging, and increasingly now we're moving into the space of biomarkers and multi-omics. So the goal here, of course, is to predict physiologic transitions. For example, is my patient going to develop a severe infection called septic shock? Clinical outcomes, is my patient going to survive? Is my patient going to have a good long-term neurological outcome? And also clinical endotypes, which are these subgroups or subclasses of individuals who share similar biological characteristics. So in many ways, we can think of the intensive care unit as the end of the line. It's the last line of defense in medicine, right? So when people have truly fallen over the cliff, that's when they arrive in the intensive care units. This is when they are very, very sick. Many different organs typically are involved. And the question is, can we rescue them from this life-threatening illness? The obvious question, of course, for me and for many of my colleagues is, can we go upstream and prevent this, this progression of disease? We know that every patient has a history. And can we take off these blindfolds as illustrated here in this cartoon and potentially adopt a more informed approach about predicting where a patient is going to go before they arrive into the intensive care unit, and also to prevent deterioration while they're in the intensive care unit. So the method that we've implemented in my lab, which is implemented by many other groups as well, is to use a technique called supervised machine learning. So what this means is that we train an algorithm to recognize the association between input features. So this could be, for example, the physiology that we record in the ICU, and the ground truth labels. So this could be, for example, survival, or it could be neurological outcome. And the goal of this exercise is to generate an output, which is the probability of, let's say, a favorable outcome occurring. So here on this slide, you can see the results of some of our work. This is what's called a receiver operating characteristic curve. And essentially it plots the sensitivity against 1 minus the specificity. So it provides an idea of how well a test or an algorithm discriminates between categories, right? So the higher the area under this curve, the greater the discrimination of your model. And as you can see here, we compared different models. The Apache score, which is a model that's used across the world to predict outcome in intensive care. This is a logistic regression model. And we compared that with physiology collected in the ICU, clinical records, and then a combined model using physiology and clinical records. And as you can see here, the green is the combined model, and this is the one that performs the best. We also were interested in comparing the Apache score, which again is a logistic regression model, with other machine learning methods. And here you can see, for example, random forest, gradient boost, neural network. And what you can see is that when compared to the standard logistic regression statistical model, the machine learning models actually achieved a higher degree of discrimination. The area under the curve was significantly higher, suggesting that these models are more efficient and effective in classifying individuals in acute phase. This is some very nice work coming from colleagues in Boston, where this time they're no longer using the hemodynamic and respiratory physiology collected in the ICU, but they're looking at the EEG. And essentially, they're extracting features from the EEG to predict outcome after cardiac arrest in the ICU. And you can see that using this machine learning model, they were able to achieve significant discrimination. And in using the two models that are shown here, this generalized linear model, both a time-sensitive and a time-insensitive model, the performance of the model improves with time. And this is a characteristic of some, but not all, machine learning algorithms. The more data that you give them, the more discriminative they are. This is some work that came out of a group at Johns Hopkins. Dr. Saria, Department of Computer Science, and her colleagues were very interested in looking at how simple parameters that are collected in the ICU could be used in a machine learning model to predict the onset of septic shock. And you can see here that this is a model to predict future onset of septic shock, which is a severe form of infection characterized by hemodynamic, blood pressure instability, and also by multi-organ involvement. You can see that using this model, they had better discrimination on this ROC curve compared to the current standard model. And importantly, they were able to predict the onset of septic shock about 18 hours before it was clinically recognized. So what this suggests is that these types of techniques not only have significant accuracy, but also they provide you with a window into the future. And you can see this 18-hour window here offers an opportunity potentially to intervene, perhaps by looking for sources of infection, treating them early as opposed to waiting for the disaster to happen. My group has also been interested in leveraging imaging to identify changes in the brain and to use these for the purposes of classification and prediction. So as I mentioned earlier, I work in the neurocritical care unit. We see individuals with significant brain injuries. This can be from trauma, it can be from cardiac arrest, it can be from stroke. And what we do is we use two techniques primarily. There's one called diffusion tensor imaging. This is an MRI technique that allows us to look at the white matter structures in the brain. And the other technique is resting state functional MRI, which allows us to map out the activation in the brain and to look for the coherence between different regions in the brain. So using these methods, this is a case where we looked at patients with traumatic brain injury, and we mapped out the white matter structures. The white matter are these sort of connecting fibers that link different parts of the brain and ensure that processing is integrated. And so we identified specific structures and we measured using diffusion tensor imaging the integrity of these white matter tracks. And we did this using a machine learning method called support vector machine. So we trained the algorithm to recognize the association between specific features, in this case, the diffusion tensor imaging and the clinical characteristics of the patients, and outcomes. And we asked the algorithm to predict the probability of functional outcome of 1 year. What you can see here is that when compared to the current standard, which is a clinical score based essentially on clinical features of the patients and some CT characteristics, a model that included the clinical score but also added the MRI diffusion tensor imaging data on the white matter tracts performed significantly better. You can see that the discrimination improved from about 0.6 to 0.9. What this means is that 90% of the time, this model accurately distinguished between a favorable outcome and an unfavorable outcome at 1 year after severe brain trauma. And we did We're currently working on something which is a little bit different. In this case, we are interested in the mobility or the movement of patients in the intensive care unit. We know that people, who are in the ICU experiencing critical illness have reduced mobility, but we also know that mobility or motion is an indicator of underlying neurological states, and also it's an indicator of underlying physiological states. So we've implemented a study where we placed sensors. These are essentially accelerometers measuring the movement of the arms and the legs of patients in the ICU. And we derived specific quantitative motor features, and we're using these for the purposes of classification. It's a bit early, so I don't want to show you any results just yet, but we are using machine learning models to integrate these motion time series data in an effort to predict both short-term state transitions, so changes, for example, in the level of consciousness of individuals in the ICU, but also to predict things like mortality and favorable neurological outcome, both at discharge and also 12 months later. I want to talk a little bit about something which I think is really important, and it's the notion of endotypes. So many of you recall that the phenotype is what we observe on the outside, right? So the physical characteristics of an individual as relates to their health is the phenotype, right? So this is what we see when you walk into a room and you see a patient who is lying in a bed, or when we see a patient in the clinic, we're observing the phenotype. We know that the phenotype, as per the dogma of biology, that the phenotype is driven by the underlying factors that include the genotype, so gene expression, and also a number of environmental variables. And what we don't know is what happens, we don't know very well is the relationship between these genotype and environmental variables and the phenotype. What we suspect is that there's a number of intermediate systems, biological systems that mediate this relationship, but our knowledge of how this works is still fragmented. We've certainly gained a lot of knowledge on underlying biological mechanisms such as metabolic changes, immunological changes associated with health and disease, but it's still fragmented. We don't have a sort of overriding theory of how this works. One approach is to consider these intermediate systems as endotypes. So these are specific subgroups of individuals who share certain biological characteristics and certain clinical characteristics. And many people feel that the endotype paradigm is a very important sort of concept that can be used to get closer to the underlying biology of people with disease, and can also be used for the purposes of classification and prediction. So the way that you derive endotypes is to implement unsupervised machine learning. You recall that earlier I spoke about supervised machine learning. Unsupervised learning has no labels, right? So there's no ground truth outcome variable to be fed into the algorithm. And the only thing that you have are the complex data sets, the multidimensional features of your patients. And the unsupervised algorithm is performing, in a sense, an exploration of the data. In many cases, we're talking about a process of clustering, right? So what the goal here is to identify specific subgroups of individuals that share characteristics that could be meaningful biologically and clinically. So this is some work that we've undertaken in terms of deriving endotypes of people with traumatic brain injury. So what you can see at the top of the left-hand portion of the slide are the different clusters that we identified using a very large database called EICU. So these are patients admitted to the intensive care unit with traumatic brain injury. And you can see that these clusters are very, very distinct in terms of their outcome probabilities, and also so in terms of their mortality, and also in terms of their neurological outcome. And we thought, okay, this is very interesting, but we wanted to make sure that we could validate this independently in another data set. So that's what you see in the left bottom portion of the slide. You can see MIMIC, which is another intensive care unit database. And we were able to, using the same unsupervised clustering algorithm, we were able to identify the same outcome proportions as with the initial model implemented in the EICU database. So this was very, very exciting to us. And we further carried this a little bit further. On the right hand of your slide, you can see the two of the different clusters that were identified and their specific characteristics in terms of their physiology and their laboratory characteristics. And you can see how they segregate very nicely, and how both in the initial model as well as in the validation model, there was separation between these clusters, suggesting biological veracity. This concept of endotypes is gathering a lot of interest and traction. This is a very nice paper that was published about a year ago in JAMA from the group at UPMC. And essentially, they were interested in identifying underlying endotypes of patients admitted to the hospital with sepsis. So sepsis is a severe form of infection. It's the stage preceding septic shock. And you can see that they identified 4 different endotypes. They call them phenotypes, but the terms are synonymous. The alpha, beta, gamma, and delta. And each one of these underlying endotypes is associated with a specific sort of pattern of organ dysfunction, as shown in the top portion of the left-hand side of this slide. And also each one of these endotypes is associated with a specific survival probability, which is shown on the right-hand side of the slide. You can see the 60-day survival analysis, and you can see that the different endotypes segregate quite nicely, suggesting that these specific subgroups are biologically quite distinct and have very, very specific behaviors in terms of their outcomes. So what is the importance of endotypes? The importance of endotypes is that this might help us better identify specific subgroups that could help implement, trials, for example. So that's this concept of purifying your sample and selecting patients for treatment as opposed to treating indiscriminate or undifferentiated samples of patients who share the same diagnosis, but which are very, very heterogeneous, as we discussed at the beginning of this talk. So I'm going to try to wrap things up by talking a little bit about why precision medicine is relevant now, why we need it now, how it could be used to defeat pandemics. And we'll talk a little bit about the biology of the virus of SARS-CoV-2. We'll talk about the biology of the host response. We'll talk a little bit about the use of machine learning to support diagnostics, syndromic surveillance, and digital contact tracing. So this is a very nice study just published a couple of weeks ago. There was a genomic analysis of the SARS-CoV-2 virus, and they wanted to identify whether there were specific characteristics of the SARS-CoV-2 virus, as well as the SARS-CoV virus, which was responsible for the the pandemic in 2003, and the MERS-CoV virus, which was responsible for the pandemic in 2009. And sure enough, by performing a genomic analysis, they focused on the spike glycoprotein, which is the very characteristic glycoprotein that envelopes the RNA in the virus and accounts for the name corona. It gives the crown-like appearance of the virus. And what they found was that there were specific residues on the spike glycoprotein which were quite different in the highly pathogenic coronaviruses when compared to the much less pathogenic coronaviruses. As you know, coronaviruses are responsible for a range of different kinds of diseases, including the common cold, which is almost always completely benign. But what we can see here is that the spike glycoprotein in these pathogenic strains of coronavirus, again, especially in the SARS-CoV-2, are different. And this may provide at least some explanation as to why the disease is so severe and so significant in the case of SARS. What about the genetics of host susceptibility? So this is a very nice paper coming from a group in Europe. And this plot is what's called a Manhattan plot. And it identifies specific gene locations that are associated with a higher likelihood of getting SARS. So they compared individuals, several hundred individuals who had the SARS-CoV-2 infection and controls who did not. And they looked at their genomes. And so you can see on the bottom of this graph is the different chromosomes, going from 1 all the way to 23. And the y-axis is the probability of an association between the gene expression and the outcome of interest, in this case, COVID-19. You can see that they identified 2 loci, one on chromosome 3 with a series of different genes, and another in relation to the ABO blood type that seemed to confer a higher risk of getting COVID-19 compared to controls who did not get the disease. I wanted to show you also this very recent paper published from a group in China looking at the host response to infection. So here they used data from several different groups: healthy, controls, hospitalized patients with COVID-19, patients with severe COVID-19, and patients with non-severe COVID-19. And they extracted the proteomics, which is essentially a panel to look at all the different kinds of proteins that are expressed in the bloodstream of these individuals. And they also did metabolomics to look at specific metabolic factors associated or not with different phenotypes. And the result of this analysis, which is, I think we should consider preliminary, but it's very, very nicely presented. You can see that there are specific proteins that have been linked to not only the presence of the disease, but also to more severe forms of the disease. These have to do with the activity of macrophages. Macrophages are those scavenging white blood cells that perform many defense functions in the bloodstream and in the tissues. Also, factors associated with degranulation of platelets. Platelets are those very small cells that circulate in the blood that are very important for the coagulation system. And then a number of different metabolic products were also linked to the presence or absence of the disease, as well as to the severity of the disease. So what this is doing essentially here, this study is mapping out the relationship between specific phenotypes and the sort of high throughput biology as seen in the bloodstream of individuals with or without COVID-19. So there's also another aspect of how we can address this disease, and this is through syndromic surveillance. I think we know that in the general population, as shown on the right, that the vast majority of people are not infected. We know that probably the number of infected individuals who are symptomatic are vastly outnumbered by the number of infected individuals who are asymptomatic. And this is a very different population from what we see in the hospital, where we have higher numbers of infected individuals, many of whom are symptomatic. And so the question is, can we set up a system to monitor people in the population in terms of their symptoms, and potentially by evaluating symptoms, predict where there are hotspots or outbreaks of disease that are going to be occurring. And so this is COVID control. This is a study that I've had the pleasure of participating in. It's a collaboration between colleagues in the Johns Hopkins Bloomberg School of Public Health, as well as colleagues in the Whiting School of Engineering and colleagues in the School of Medicine. And so essentially we have an app. You can download it. It's available on the different platforms, iOS and Android. The app is downloaded to your smartphone. And using this app, you can introduce data on your symptoms. So, for example, do you have a cough or not? Do you not have a cough? Do you have trouble breathing? Do you have loss of sense of smell or taste? Or do you have no symptoms whatsoever? And these data are aggregated and then are used using machine learning. Essentially, we're able to map out the distribution of symptoms across the country on a county-wide scale. So just very important to realize that this program is completely de-identified, so we have no way of tracking individuals, but we are able to track symptoms at a county level resolution. And the hypothesis here is that we are able, using symptom tracking, we're able to predict where there are outbreaks of the disease that are going to be occurring in the near future. So this is work that is ongoing. We have a prediction model that is being validated, and I'm happy to share that with you as soon as it's ready. The other piece that is obviously very important is digital contact tracing. And what this involves essentially is individuals using devices like smartphones or tablets to record whether or not they have symptoms. So you have, for example, here, individuals A and B. Individual A takes the train, comes into contact with individuals C and D. At work, this same individual A interacts with individuals E, F, G, and then goes back home. And on the next day, this same individual has a fever. So by entering that data through their smartphone or tablet, that person A immediately alerts the people that he or she was in contact with. So for example, individuals C and D, and the people that that person encountered at work. And those individuals are immediately placed on social distancing and quarantine, so thereby reducing the risk of transmission. So this is obviously a very, very exciting direction that many, many countries have adopted. There are many, many issues related to privacy that are obviously have, justifiably been elicited, but it's believed that this represents an extremely robust methodology to, in a more selective and precise and personalized way, to reduce the likelihood of viral transmission in the community. So I just want to sort of wrap this up by giving a few sort of points about what this means for us. I hope that I've been able to give you a flavor of the fact that precision medicine leverages data science and mechanistic insights to maximize the health of individuals. I believe, and many of my colleagues believe, that biologically driven classification can optimize the design of clinical trials in both acutely ill patients, but also during the recovery period and also in people with chronic diseases. We think that precision biomarkers can be used to select candidates for specific therapies and track the efficacy of that intervention. We believe that predictive models can enhance discrimination of recovery probabilities. And I believe, and many of my colleagues as well believe, that the precision medicine can change not only the way that we practice research and clinical care, but potentially could touch upon many different aspects of the health system. And so in this slide here, I wanted to show you this notion that a precision health system certainly would be a major driver of scientific discovery, and it could accelerate the implementation of clinical excellence. We think that it could enhance safety and quality, but we also believe that it could have an impact on operations and finance. If we are more effective and more efficient in our treatments, in the end, we will save money. And also, we can be more personalized in the way that we teach and in the way that we learn. So I think that this is a sort of kind of a nice overriding or overarching paradigm that could be very, very valuable today in health and also in the future. So I want to just acknowledge a large number of collaborators here at Johns Hopkins across different schools, different departments, as well as many, many colleagues and collaborators across the world. And this is just a partial list. And I will stop there. And I think we have about 15 minutes. So I'll be more than happy to take questions from many of you. Thank you very much. I am looking at the questions here, and from Stella, what is the biggest barrier to making the shift to precision medicine as the primary approach to care? So I think that's a great question. I think it's the biggest barrier is a cultural and cognitive one. I think that there's no doubt that the methods, the concepts that I've advanced are both extremely attractive and appealing, but they are disruptive. And what we need is for people to understand that precision paradigms, personalized or individualized medicine is beneficial, and that it can reduce cost, and that it can be implemented at many different scales. I hope that begins to answer your question. Another question from Linda, can you talk about the role of precision physiology sets that can be targeted in pathophysiologies, and possibly comment on some generalized differences between males and females? Yeah, so we, as an intensive care physician, I'm very interested in physiology. It's sort of the basis of what we do. Certainly I think, the data that we have access to in the intensive care unit from the physiologic monitors, as well as more advanced data sets, are extremely, we think, are extremely valuable. And we've only started to leverage the ability, the capabilities that we can implement with those techniques. I think what's probably more important is that the physiological data sets that we collect in the ICU could, and I think in the not too distant future, be also available for patients outside of the ICU. So if we just take the hospital setting, my dream is to be able to monitor patients throughout the hospital, to be able to know what their physiology is so that we can capture them before they deteriorate. And then I would like to expand that even to outside the hospital and consider individuals who are at risk and who are at home or who are working, people with chronic diseases who are definitely have an increased probability of experiencing a physiologic decline. I would like to, using wearable or implantable sensors, be able to implement monitoring on those individuals and hopefully determine ahead of time that they will become sick. I think in the ideal world, we would not have intensive care units because we would become so good at making these predictions and identifying people ahead of time before they get really sick. Okay, from Gabriella, precision medicine seems positive for the patients and helpful to physicians. How would we deal with the risk of insurance companies not paying for someone who may show negative outcomes statistically? Yeah, so this is also a really, really important question, and I think we can say that whereas many academicians and an increasing number of corporations have are investing heavily in precision medicine and have bought into this concept, such may not be the case for other parts of the health system, including insurance companies. And I think our job, people like myself and other folks in the health, in medical academics, should really focus on a work of dissemination. We need to go out into the community. We need to talk not only with our peers and people who understand us, but also with, for example, regulatory authorities, as well as insurance companies, so that they understand the true value of individualized or precision medicine. And in the case of someone who statistically would not respond to a therapy, I think that is a specific scenario that is very difficult, actually. So if we have a prediction model which shows that somebody is not going to respond to a therapy, I think we should obviously follow through in terms of our practice. We should not be implementing therapies that are not going to be effective, and we should be searching for new therapies that would be effective in that specific individual. So another question from Jay: what is the potential for bias using machine learning, artificial intelligence to predict outcomes or inform treatment? So this is also a hugely important topic. We could spend the whole day talking about bias. Inevitably, the machine learning algorithms are trained by people, by us. And in those training exercises, we certainly do introduce biases, multiple different levels of biases that could affect the performance and the outputs of these models. I think we're just at the beginning of recognizing how to nail down those biases and try as best as possible to develop less biased algorithms. I think it's a field that is ripe for growth. So another question from Mac. How does this type of robust collaboration come about? Does it grow from an individual's interest, or are there institutional mechanisms that drive and support this? So I have to say that I think I'm very fortunate being a professor at Johns Hopkins. I have the ability to engage with a large number of collaborators across many, many different schools, departments. And this is not a unique feature of Johns Hopkins. It's a characteristic of many large academic medical systems and universities across the world. I think inevitably the collaborations only come about by the combination of a few things. One is investing a lot of time and energy. I think another is asking the right questions. And also, I think, being humble and recognizing that paradigms that we have developed ourselves or paradigms that have existed in the past may no longer be valid. And so I think the combination of humility as well as energy are important drivers in developing these kinds of collaboration. I think maybe luck also plays a role, but certainly the environment such as the one that we have at Johns Hopkins is extremely fertile for these types of collaborative engagements. So here's another question from Joe. What are the privacy concerns related to developing an app-based contact tracing? They're huge. Great question. I don't know that anybody has solved this issue of privacy as it relates to digital contact tracing. I think there are some very elegant solutions that people have proposed. But inevitably, the concern that you express about privacy of individuals are real. I think in a perfect world, we would obviously not have digital contact tracing. This is really a question of necessity. Are individuals in society, willing to maybe relinquish some of that privacy in order to serve the greater good of identifying, people who are infected, people who are at risk, and properly separating, uninfected from infected individuals or people at risk. So I think there's a trade-off inevitably. I don't know that there is a global solution for the privacy question that you raised, Joe. Last question. Are there any places in the world that you feel serve as a model for the use of precision medicine in healthcare from an application standpoint? Yeah, so I don't know that there's a specific health system or country or region where people are practicing precision medicine in the ideal fashion. I do think that there are centers in this country that are in the forefront. Certainly Johns Hopkins is one of them. I think Stanford University, under the leadership of their dean, Lloyd Minor, who's actually from Johns Hopkins, has made huge strides over the past 10, 15 years in this space. There are certainly very, very powerful precision medicine initiatives that are developing in places like Columbia University, University of Pennsylvania. So there are certainly institutions and health systems that are heavily investing in precision medicine. I don't know that there's a specific place in the world where this is happening apart from the institutions that I mentioned. Ideally, of course, we would want the federal government to think about how precision medicine could be a value generator for the types of universal health coverage that many feel will be necessary in this country. So I'm being told that I need to wrap, which is sad because I really enjoyed this. I actually I'm very grateful again for Hopkins at Home and also for Johns Hopkins University to host me for this program. I hope that you enjoyed listening about precision medicine. I hope that you will be able to think about ways to implement it. And I will sign off now and hope to see you all again very soon. Thank you and take care.